as well as Hemocare Hematology Center, Thane, Mumbai. Dr. Shilpa Gupta from Holy Spirit Hospital, Andheri, Mumbai. Hospital, Mumbai. Dr. Sumit Mirik from Tata Memorial Center, Attract, Mumbai. Dr. Venkatesh Darshan from Tata Memorial Hospital, Mumbai. Now it's time to introduce our special guest and chief guest for the day. We have with us Dr. Gaurav Dixit from Gurgaon. Dr. Gaurav Dixit is Unit Head of Hemato-Oncology at Artemis Hospital, Gurgaon. And it's my pleasure to invite Dr. Gaurav Dixit to create our webinar and give some words of wisdom. Over to you, Dr. Gaurav Dixit.
Thank you very much, Dr. Amit. And my sincere thanks to Mumbai Hematology Group and Agrawal sir, who has been a mentor and teacher for most of us. So there has been so much to learn from his vast experience. And I can see so many people who have joined this webinar. It tells us about the interest in hematology, which is growing in our country. And it also tells us the quality of webinar, and sir has been persistent and like unrelenting force for development of hematology in this country. So the most important thing to learn from him is persistence. And if we have passion for something, probably we should follow it through our heart, and it will help us grow. It will help us in serving our patients better. We all know that hematology is a very new branch in India as compared to the other branches, cardiology, nephrology, and there are so many new things which are coming up in our branch. We have seen how classifications have shifted from morphology based to more of genomic based. And like in AML, leukemias, it is already there, and it is slowly developing in lymphomas also. We are slowly adopting genomics in lymphomas, DLBCL, which I'm very sure which we will discuss next week in our webinar. So there are a lot of things, and although it may seem difficult to follow, but ultimately it helps us in determining, genomics helps us in determining the way forward, prognostication of the disease, target agents which we can use. We have to embrace genomics in a bigger and better way going forward. And lastly, I would like to advise or maybe tell my juniors not to afraid to work in second tier cities. And there is lot of scope in second tier cities. There is lot of deficit of services which we are feeling there. Even in my state, Haryana, there is hardly any hematologist. Maybe I can count on my fingers. It is definitely not adequate. We should not be afraid, and probably we should keep working for a greater good. And lastly, today's talk is a very interesting talk by Professor Lamy, and it's about LGL leukemia, about which I have a limited experience. I am looking forward to this talk, and I would like to hand over back to Dr. Amit and organizers for further discussion. Thank you very much, MEG again. Thanks.
Thank you, Dr. Gaurav Dixit, for that wonderful and kind words of wisdom. And thank you for accepting our invitation as our chief guest for the day. Thanks a lot. Let me share the screen once again. So now it's time to introduce our guest speaker for the day. We have with us Dr. Thierry Lamy from France. Dr. Thierry Lamy is the head hematology department at Rennes University Hospital, France. He received his MD in 1988 and PhD in 1998. He was professor in medicine in 2001, and he has been involved in lymphoma group of the Goelem group and was one of the pioneers of the creation of the LYSA group, that is Lymphoma Study Association, in January 2012. He is a co-director of the scientific committee of the LYSA. His academic activities include lymphoma clinical trials and LGL leukemia. He is also a member of the research unit INSERM U917, Director PRK Turkey, which focuses on microenvironment and lymphoma. And today he's with us and he's going to lecture us on LGL leukemia. Well, thank you so much. Over to you, sir.
Okay, so can you share the screen?
Yes, I will stop sharing the screen. Sir, you can share your screen, sir.
Can you see it?
Not yet, sir.
And is it okay?
No, we are not able to see your screen.
Oh, is it okay?
Perfect, sir. Please go ahead.
So, dear colleagues, it's a real pleasure to share with you the last update of TNK large granular lymphocytic leukemia. So it's a real pleasure to share with so long distance from France with you, all you people. And so I will give you this talk with 4 parts. Just a few words regarding the historical recognition of the disease, and then the clinical biologic presentation. Then I think it's very important to depict the last update of the pathogenesis of the disease, especially molecular features, and we finish with the treatment of LGL leukemia. So as you know, the large granular lymphocytes are normally present in the circulated blood with a relatively low normal value at 0.25 giga per liter. It's composed of large-sized lymphocytes containing cytoplasmic azurophilic granules and a round nucleus. Usually, we don't ask the biologist to give back the number of LGL circulating cells. But I think in certain circumstances, we have to ask the biologist to count exactly, especially in the context of hyperlymphocytosis or unexplained neutropenia. So just regarding the historical recognition, it's more than 50 years ago that some description of patients having neutropenia and excess of lymphocyte has been described, and it was not CLL because these cells express a marker of T or NK lineage. And the first description was made 30 years ago by Tom Logrance, published in Blood, and it was a pioneer of the description of the disease, which separate two different entities, the T CD3 positive subtypes, which account for about 85% of the cases, and NK CD3 negative LGL leukemia, which account for 15% of the cases. And so the LGL leukemia has been included in the WHO classifications in 1999 and in the recent one on 2022 with two different entities, T and NK large granular lymphocyte leukemia. And you have also a separate third entity which is very rare called aggressive NK LGL leukemia, but I don't speak about this disease. And between the first description and right now, there was, I think, three major points depicting the molecular feature on LGL leukemia with three mutations, occurring respectively for stage 3, TET2, and CCL22 mutation. The incidence of the disease is relatively low, between 0.2 and 0.72 per million per year. It's average published in US and Europe. I don't know exactly the incidence in Asia. The median age of diagnostic is 65 years old, with no difference between male and female. The incidence, it's about 5% of chronic lymphoproliferative disorder, and it's very close to that of LGL leukemia. And which is fascinating in the disease, it's a very diverse behavior of this leukemia. On this slide, you can see that you may observe some very asymptomatic patients who probably will not need treatment, and you have about 20% of patients with just a watch and wait attitude. Some patients, the majority of patients, will need treatment essentially for neutropenia associated infection or anemia. And the relapsing patients, because most of the patients relapse, will not need a treatment for about 20 to 30% of patients. And the refractory or relapsing patients will need also different treatment. I will talk later on of the targeted therapies that we can propose for this patient. And we observe in certain time a very aggressive form of disease. And at least in France, we have per year 2 and 3 patients we need allogeneic bone marrow transplantation. Nevertheless, the LGL, you know, and here, so on the French and the Italian study, you can see the very good overall response rate and overall survival, with about 70% of patients being alive at 10 years after diagnosis. But as you can see on the left, the deaths are mainly due to the progressive disease and mainly due to the infections associated with chronic and resistant neutropenia. What about the clinical biological presentation? On the left, you can see the clinical presentation, which usually are based on recurrent infections occurring in about 50% of patients, B symptoms, and splenomegaly. The particularity of this disease is the association with autoimmune disease, occurring in about 10 to 15% of cases, and mainly rheumatoid arthritis. We will see later on all the disease which can be associated with this leukemia. The biological features are dominated by the neutropenia, about 80, 50, 80 and 85% of patients have neutropenia, and 25 severe neutropenia below 0.5 Geiger per liter. The amount of lymphocytosis is quite different that observed in CLL. You can see that only 10% of patients have LGL count above 10 Geiger per liter. So you can see that about the majority of patients have LGL between 4 and 10 Geiger per liter, and which is very important that in certain cases, the amount of LGL is quite low, between 0.5 and 1 Geiger per liter. And it's very important to know that, because in this circumstance, you have to make a phenotype if you suspect LGL leukemia. 20% of patients are transfusion dependent, and a minority are thrombocytopenia. And marrow infiltration, when marrow biopsy or medullary punction is made, is relatively common, about 70%. And a particularity of this disease is association with autoimmune cytopenia, occurring between 5 and 10%, with pleural aplasia, ITP, hemolytic anemia, and cyclic neutropenia. Regarding the hematological manifestation, what you can see on this slide, it's commonly observe polyclonal hypergammaglobulinemia in about half of the patients, some case of gammopathy, monoclonal gammopathy, and two markers, the elevation of beta-2 microglobulin, like you can observe in different kind of lymphoproliferative disorder, and a very high level of soluble Fas ligand, which is not obviously done in routine, but we published that 20 years ago, and it's a very good specific marker of this disease. What about the associated disease, which has been updated for the last reviews that we have recently published in Blood? You can see a bunch of associated disease. The problem is to know whether or not there is a link between LGL leukemia and all this disease. I will mention rheumatoid arthritis, Sjogren syndrome, autoimmune cytopenia, and it's also frequent to see association between LGL leukemia and solid or hematopoietic neoplasm. It's very difficult to know if it's linked or not because you observe that disease at the age of 65, 70 years, so it's commonly see to see such associated disease. And at the bottom of the table, you can see some specific disease. And in this disease, we can really observe some physiopathological features and can link LGL leukemia to inclusion body myositis, pulmonary arterial hypertension, and common viral immunodeficiency. What about aggressive LGL? Just one slide to see that it's very rare, very aggressive, and I would say that probably it's one of the most aggressive hematological malignancy with the overall survival at less than 6 months. It's very aggressive with organomegaly, GI, CNS infiltrations, and massive pancytopenia. So I won't talk about that. What is the diagnostic procedure on LGL expansion? Usually, you can see there is a clinical biological context which can make you suspect LGL leukemia. It's recurrent infection, neutropenia or anemia, splenomegaly, pancytopenia, lymphocytosis, whatever. So you have, in this context, to perform CBC. And on CBC, you ask, or the biologist say, there is LGL expansion, and after you perform immunophenotyping. And after, if you see that there is a clonal, or there is an expansion of LGL, you have to perform the clonality, mutation profiling, and in some case, marrow histology, because at the end point, it's very important to make the distinction between reactive LGL expansion and LGL leukemia. In fact, the reactive LGL expansion can be observed in certain circumstances, such as after splenectomy, during viral infection, after stem cell or organ transplantation, and it can be sometimes associated with autoimmune condition. But in these cases, usually in reactive LGL expansion, the LGL count is not so high, the neutropenia is very rare, and the incidence of infection is quite low. So what is the algorithm for the criteria? We put the threshold above 0.5, 10 times the 9 per liter, and you have specific criteria for T-LGL leukemia and specific criteria for NK-LGL leukemia based on immunophenotyping and assessment of clonality. So what is important for T-LGL leukemia subtype is usually the most commonly phenotype observed is as follows: alpha beta, CD3 positive, CD5 dim, CD8 positive, and CD57 positive. And after, you have to assess the clonal rearrangement of the TCR to prove the clonality. Regarding the specific criteria for NK-LGL leukemia, as you know, it's difficult and impossible to assess clonality because the cells do not express TCR. So you have to take into account the phenotype, which usually is CD3 negative, CD8 positive, CD16 positive, and CD56 dim, and with a specific KIR restriction expression pattern. And it's depicted on this slide. You can see here the example of a T-LGL leukemia. So more precisely, the T-LGL display a terminal effector memories phenotype, CD8 positive, CD62L negative, and CD45 positive expression. Interestingly, it has been published this year that a good marker which can be expressed either on T or NK LGL supply, so-called KLRG1, expressed, and is very interesting because now it's considered as a target for a specific monoclonal antibody against KLRG1. And when you assess TCR clonality, you can do it regularly by gene scan or height-through sequencing analysis. You can see the difference between polyclonal and LGL patient with a monoclonal peak. And you can also assess clonality with using specific monoclonal antibody directed against repertoire of V beta. And you can see on this slide the expression, the monoclonal expression of V beta 11 in 87% of case of cells, which assess the clonality of such a patient. Well, regarding the NK cell differentiation, you know that there is at least 6 stage of NK differentiation, and the NK-LGL belongs to the stage 5 with a specific dim expression of CD56. And you can see here the example of pattern with CD3 negative cell, the CD56 bright, and the CD8 positive cells. And when you use different panels in our laboratory depicting inhibitory or activating receptors, what we can observe, you can see on the right-hand side, the very specific KIR restricted phenotype with at least loss of expression of 2 KIRs with a high level of expression of CD99 on NKG2A. So you can easily make the difference between a reactive NK polyclonal LGL extension as compared to clonal NK LGL expansion and NK LGL leukemia. So you can see the global heterogeneity phenotypically of LGL leukemia with either NK subtypes, 10 to 15%, T alpha beta CD8, which is the most important LGL leukemia subtype, and very rare CD4 negative, who usually are stage 5B mutation, and some case of LGL CD3 T gamma delta positive LGL leukemia. So what is the algorithm to make the diagnosis? First, the phenotype. Second, the molecular analysis we'll see later on. And usually you can easily separate polyclonal and true T or NK LGL leukemia. And I call between these two parts the gray zone, with I think it's referred for patients having some kind of cytopenia, low LGL count, but no clonality, no recurrent mutations, and you have in these cases to perform a bone marrow biopsy. And what you can see, it's a specific cluster of at least 8 CD8 positive lymphocytes with a linear array of intravascular LGL leukemia. So if you perform bone marrow biopsy, you have to ask the histopathologist to perform immunochemistry with CD8, CD57, TIA1, and granzyme B to exactly observe the LGL infiltration. What about the pathogenesis of the disease? So at this time, we can consider initially there is an initiating event coming from viral peptide or autoantigen, and promote also pro-inflammatory cytokine context like IL-2, IL-6, and IL-15. And the second part is the oligoclonal and clonal expansion associated with disease immunity, some kind of clonal hematopoiesis with STAT2 mutation and CCL22, which are associated with interaction with the microenvironment, and next STAT3 mutation. And the last part is the development of LGL leukemia with molecular alteration, cell proliferation, and apoptosis dysregulation, and then the tissue aggression with marrow infiltration, spleen infiltration, and explaining the neutropenia, anemia, and associated with autoimmune disease. So I have not the time to depict all the different specific steps of the LGL clonal expansion, but I just focus on this point. It has been shown a long time ago there is potential HTLV1-like inflection, but and the reason is that about half of the patients have a seroreactivity to BA21, which is in envelope protein close to HTLV1. But so it's very interesting because 50% of the patients is quite high. But when you perform the search for retroviral insertion, you don't see any insertion of virus in the DNA of the cells. The second point is in importance of the cytokine signaling and especially IL-15. IL-15 is probably one of the cytokines most involved in the pathogenesis of LGL leukemia, which promote oncogenic survival signaling, pro-inflammatory cytokine, and epigenetic modification. And first, it has been shown that IL-15 is widely expressed in LGL leukemia. It has been published a long time ago. And there is a very nice paper published 12 years ago by Mishra on animal mouse model, which were with overexpression of IL-15. And in this mice, you can observe after IL-15 exposition, a large spleen, a blood smear with massive infiltration of LGL, and interestingly, they observe that the IL-15 signaling may promote a semic expression and DNMT3B and also chromosome instability. And it's the first demonstration of the incidence of hypermethylation in LGL leukemia in animal model, but it has been shown later on in patient also. So regarding the mutations, I will go on the different mutation, and you know that STAT3 it's a major receptor activating promoting signaling, and it has been shown a long time ago that we published in Blood more than 20 years ago that the LGL cell are quite resistant to FAS-induced apoptosis. And in these cases, there is no FAS mutation, but constitutively a FAS resistance apoptosis. And it was shown by the Thomas Lugran's lab that in these cases of LGL leukemia, you can observe a constitutive activation of phospho-STAT3 for all the patients. And when you block the induction of apoptosis with a specific STAT3 inhibitor, you restore the apoptosis. So we have to wait 10 years later to see that there is STAT3 mutation. It has been published in New England Journal of Medicine 12 years ago, but the Finnish team of Satu Musowski. And there is at least very different variants of STAT3 mutation, but occurring mostly in a SH2 domain, like as you can see on this slide. And the mutations are located on the dimerization interface that mediates STAT3 activation, and they increase the hydrophobicity of the STAT3 SH2 dimerization disease surface. And initially, they report that they observe STAT3 mutation in both subtypes, T or NK, with the occurrence of 30%, with different, as I told you, with different mutation points maybe occurring in the same patients. And interestingly, it has been suggested that the behavior of patients having STAT3 mutation was a little bit more aggressive as compared to wild-type STAT3 mutation patients with a higher incidence of neutropenia and cytopenia. But I think we have to be cautious about these results. And what we observed in the French study, about more than now 150 patients, but we published on 120 patients, that the incidence of STAT3 mutation was quite higher. And as you can see, it's observed, and we observe in about 70% of patients. And when we perform the dedicated panel, the NGS sequencing, you can see that in red, you observe effectively 70% of patients having STAT3 mutation, but you can also observe STAT5B, and most and certain gene mutations involved in NF-κB pathway and also in DNA methylation. And you can observe the TNF-IEP3 mutation occurring in 10% of patients, and some patients have the coincidence of different mutations. What about TET2? So it was interesting to focus on TET2 mutation because you know that it's involved in clonal hematopoiesis, mild dysplasia, and it has been shown that TET2 mutations alters NK function in at least myelodysplasia, but they are not observed in normal T cells in patients having hematopoiesis, clonal hematopoiesis. And we observe also some TET2 mutation essential lymphoma such as AITL. So we were interested in testing TET2 mutation at least in NK, and we published 3 years in blood for the first time the identification of TET2 mutations. You can see on the left-hand side occurring about 35 patients of NK LGL leukemia, and as you shown initially, you can see that you don't see, or very rarely, the occurrence of mutations in reactive NK cells as compared to authentical NK LGL leukemia. And interestingly, you can observe also that STAT3 mutation and TET2 are mutually exclusive in these patients. And it was confirmed by the American study 2 months later after our publication. So we try to identify whether or not the TET2 mutations are observed only in AK cells or also in myeloid. And you can see on this slide that we can observe in sometimes a combination of NK occurring in both subtypes and sometimes only in NK cells. So we can probably suggest that in certain cases there is only STAT3 mutation observed in certain patients with a specific biological patterns, and in sometimes the first hit is TET2 mutation, and then you have a secondary additional mutation or modification, and you have in these cases a different phenotype. What about CCL22? CCL22 is a member of the chemokine family, mainly produced by macrophage and dendritic cells and binding to CCR4. And it was published 2 years later by Barrère in Nature Genetics, and you can see that they observe at least that 30% of patients have CCL22 mutations only in NK subtypes. It's not observed in T LGL subtypes. And once again, it was separative because you can see that the expression of the mutation of CCL22 and STAT3 are mutually exclusive in this context. And it was very interesting to see that this patient have a specific phenotype, CD56 and CD16 DIM, and some of these patients present with polyneuropathy, tremor, and psoriasis, and we have to figure out where is the link between CCL22 mutation and the symptomatic clinical symptoms. I would move on. So we can consider that there is a continuum between the, I would say, the baseline of LGL leukemia, indolent patients, and the aggressive form of the disease. You can observe the different steps that I have described previously, and probably there is a continuum between the indolent disease and aggressive on the right, occurring after different steps, which can lead to the aggressiveness of the disease. So in summary, and we published recently in Blood, you can observe the different phenotypic and molecular heterogeneity of the disease occurring in both subtypes, T-LGL and NK-LGL leukemia, with stage 5B, stage 3, TET2, and CCL22 mutation. And so I think it's very important to figure out that probably this patient behave differently depending on the specific molecular status, and it will be important to take it into account regarding the therapeutic administration. So in summary, you can observe on this complicated slide that the first step is at the top, the cytokine signaling with IL-15. The second is a fast-induced apoptosis inhibition with different steps with elevation on CFLIP, diminution of SOX3, and activation of phosphostatin 3. The signaling the survival signaling, making the cells surviving, and also the DNA hypermethylation. So the last point of the physiopathologic feature is the association with T-LGL leukemia on autoimmunity, and we have to focus on the I would say STAT3 gain and function mutation we can observe in infants and also in different kinds of disease. And a very nice paper which has been published 2 years ago in Immunity in May brings the proof that the gain of function STAT3 mutation may lead in autoimmune disease in mice, may cause accumulation of NKG2D positive and CD57 positive in both mice and human, and may induce overexpression of cyclone and killer gene. So they nicely shown in this study that STAT3 mutation may induce autoimmunity and also NK-LGL expansion. So I think it's very important to see that probably it is the first step to understand why you can observe some autoimmunity feature in the context of LGL leukemia. And finally, I will go on how do we treat LGL leukemia. That's the current algorithms that I present for the treatment of LGL leukemia. So you have to treat patients who present recurrent infection associated with neutropenia. It's mainly, I would say, systemic infection, but also recurrent stomatitis or mouse infection. So maybe in some time it's just the 1 point that you have to treat the patients. Also patient with anemia, and there is a backbone is to use one of the 3 drugs, cytoxan, cyclophosphamide, methotrexate, and cyclosporine in metronomic administration at 100 mg per day for cytoxan, 7.5 mg per meter square once a week for methotrexate, and 3 mg per day for cyclosporine. Usually my recommendation is to treat patient at least 4 months. It's not necessary to make the evaluation before. And for responder, you can pursue the treatment for at least 12 months. You stop, especially for cytoxan, because of the mutation and the side effects. And for the non-responding patient, you have to switch for one of the 2 drugs which has not been used as baseline. What about the results? It's very difficult because we have many series of retrospective series which may display different bias. So it's very complicated to see what is the best of the 3 drugs. And you can see that the comparator rate is very diverse from a study to another, occurring between 14 to 50% for methotrexate, 38% for cytoxan. In cyclosporine, you don't observe complete phenotypic results. It's a very good drug for restoring and correcting cytopenia, but there is no effect of the clonal expansion. So very difficult to assess, but there is one study which has been published by the ECOG by Tom Logran of 54 patients. And you can see for methotrexate, the response rate was quite low at 5%. What about the other proposition of treatment? Chemo, purine analogs like fludarabine, bendamustine, deoxycytidine, and so on. It's very difficult. Usually you have a good overall response rate, but not long remission duration. I won't recommend splenectomy because of the side effects. And Compat is probably a good drug because CD52 is expressed as a cell surface, but you have to use very cautiously because of the CMV infection and of the death infection, which can occur, like you can see on this study, in about 7 cases. So very cautious about Compat. And there is an interesting paper which could be published probably in 1 or 2 months by the Jonathan Breimer team, which published interesting data on Compass using low dose with sub-Q administration. What about our program? So we launched a study in France 10 years ago, so it's a long time, with a randomization of methotrexate as compared to cytoxan. We have included 166 patients, so I can't tell you the result because it has been accepted at the next ASH meeting. So in 2 weeks, I will present the result of the study at the ASH meeting. And what about the other possibility of treatment? On this slide, you can see the different pathways that have rapidly depicted to you on this presentation, but you can imagine that you have specific targets that you can focus on with specific drug like JAK inhibitor, anti-STAT3, RAS inhibitor, cytokine signaling blockade, and specifically IL-15. Also, proteasome inhibitor like bortezomib, and also hypomethylation agents. So I would focus on these new drugs. And recently, there was a paper published on the IL-15 cytokine targeting. It was, I think, like a proof of concept on 20 patients, refractory patients, being treated with a specific inhibitor of IL-15, and they observe some interesting response, for partial response. Some patients became transfusion independent, but I think it's probably proof of concept. We'll see later on if it's possible to pursue the kind of therapeutic. And we published 6 months ago our experience of ruxolitinib, because there is a rationale, you have understand the rationale for blocking JAK-STAT pathway. So we treated 21 patients refractory to immunosuppressive agents, and we observed, very interestingly, a very good overall response rate with 3 patients entering a complete remission, 15 partial remission, and you can observe the increase of hemoglobin level rising from 9.8 to 11.9, the improvement of neutrophil counts and also of platelet counts, with a median progression-free survival at 24 months. So I think in this setting, refractory patients, at least ruxolitinib may induce good response rate. What about hypomethylating agents? And it has been nicely shown that patients having STAT3 mutation may induce elevation of DNMT1 or also DNMT3, making DNA hypermethylation. So the use of 5-azacitidine may block SHIP1 and also restore the diminution of DNMT1 and block the DNA hypermethylation. And we nicely observe in a patient, it's just one case, so it's very difficult to draw any definitive conclusion. But just you can see on this case, it was a young patient that I treat in Rhine in my department. A long story of cytopenia, purate cell aplasia, and this patient had received cyclosporine, methotrexate, and so on. She received ruxolitinib with a good response, but after 2 years, she relapsed. So I treat this patient with 5-azacitidine, 4 cycles, and we are now more than 2 years after the end of this treatment, and this patient is in complete clinical response and in complete molecular response. STAT3 mutation is no longer observed in marrow and blood. And I would finish on the last paper we recently published. And as I told you, of the killer cell lectin-like receptor G1, KLR-G1, which is highly expressed of T or NK/LGL leukemia. And there is a rationale to treat with the specific monoclonal antibody, at least in T-cell malignancy. But we'll see the result, which is study is just ongoing. And just to show you that probably we are this time, we have to move forward between the classical immunosuppressive agent to new targeted therapy. And is a summary of the ongoing trial in LGL leukemia, targeting allele-6, KLRG1, PI3 kinase delta, CD4 and 94, STAT3, JAK2, and cereblon. And also there is lastly a program with oral azacitidine in LGL leukemia. So very interesting. We have to wait and to see exactly what is the best combination, or probably to adapt the treatment according to the molecular features that we observe in these patients. So in summary, I would say that TNK LGL are part of the same disease, with a driven by antigen-driven activated TNK cells with the clonal expansions promoted by allele-6 and IL-15, associated with dysregulated apoptosis, hypermethylation, which lead to both malignant and autoimmune disease. There is a high clonal and molecular heterogeneity of this disease with 3 main mutations, STAT3, TET2, and CCL22. TET2 and CCL22 mainly occur in NK/LGL subtypes. The gain-of-function STAT3 mutation may induce autoimmunity. The first-line therapy is still commonly used, methotrexate, cytoxan, cyclosporine, but the final results are quite disappointing. And so we have to move for targeted therapy, but it's very difficult at this time to say what is the best option. And we have to wait, I think, the result of the ongoing trial. So that's my last slide, just some acknowledgement with all the French participating center in our protocol, and a collaboration with Tom Lugran's team, Jonathan Breimer in Ohio, and the Italian team of Renato Zambello and Gianpietro Samenzato. And thank you for your attention. I like to take any question.
Thank you, sir, for that fantastic and lovely talk. That was beautiful. And now we have some Indian colleagues who are going to bother you with question answer session. Are you comfortable, sir? Should we proceed?
Yeah.
Thank you. Sir, if you can just unshare your screen once.
Okay. Oh, sorry.
Yeah. I request all of our discussants to please put the raising signs so that we can start our question answer session with Professor Dr. Lemmy. Yes, we have first Dr. Jyoti Shetty. Dr. Jyoti Shetty, your question, please.
Yeah, wonderful lecture, sir. In French, to say très bien. I just had one question. Are secondary malignancies common in the course of LGLs?
It's very difficult to say that there is a specific association with secondary malignancies and LGL leukemia. It's frequently associated, but you know, the median age of the disease is 55 years, so it's commonly observed to see cancer patients at this age. So my feeling is that probably there is no link between solid tumors and LGL leukemia. What we observe is some transformation of LGL leukemia. We have published 2 cases 2 years ago of clonal evolutions of LGL leukemia in aggressive T-LGL leukemia. But that's specific to hematological disease. But the association of solid tumor, I think probably it's not really specific.
Okay, and is there any specific reason why thrombocytopenia is not so common, whereas anemia and neutropenia? Is it that platelets are spared from this because of the IL-15 or something like that? Is there an association?
No, you're right. It's a very good question. I have no definitive answer to explain why the megakaryopoiesis is quite respected in LGL leukemia. I think probably that the mechanism of neutropenia of anemia is not directed against a marrow. It's probably like autoimmune. There is also the FAS story.
Yeah, okay.
You know
It's
that the
immune
FAS.
mediated, yeah.
Right.
Yeah, okay. Thank you, sir. Thank you.
Thank you, Dr. Jyoti. Dr. Sumit Milk.
Hello, sir. Am I audible?
Yes, please go ahead.
Thank you for the excellent talk, Dr. Lemi. So this question is regarding post-transplant uh, setting of LGL. We do occasionally get post-haplotransplant patients who have got maybe prior GVHT and subsequently on follow-up have lymphocytosis. And when we see the morphology and duo flow, it comes out to be an LGL. So how do you approach LGL in these patients? Is it the same principles as you do it in your otherwise LGL patients and the same treatment principles or something else? How do you approach them?
Very, very good point. I think in the context of allogenic bone marrow transplantation, you can observe effectively increase of LGL in the context of GVHD or CMV infection. And usually it's polyclonal expansions. Contrarily, there is at least some sporadic cases of authentical LGL leukemia following stem cell transplantation and with TCR clonal, with T3 mutations occurring after stem cell transplantation. So it's very, very interesting because I think probably there is no link to the underlying disease, and probably there is an effect after stem cell transplantation which can lead to authentical TLGL expansion. So in some cases, yes, I know I've been aware of patients being treated with methotrexate after stem cell transplantation for TLGL expansion.
And would it be fair enough to say that it is like a hematological manifestation of GVH or graft versus host disease for that patient?
Yes, some patients have GVHD. Yes, you're right. But in the context of GVHD, I think it's very difficult to assess if there is a specific LGL leukemia, and usually no, I have no the experience of such patients. So.
And we have a patient who has a TLGL with a hypocellular marrow. The marrow is not aplastic, but it is hypocellular for his age. He's on cyclosporin and has achieved a partial response with respect to his hemoglobin and neutrophil count. He's 4 months into his treatment. My question is, for these patients, uh, when do you think of coming down the cyclosporin? Do you wait for a complete response? And just like in aplastic anemia, we do cyclosporin taper very slowly over a long period of time. Would you follow the same principles for this patient?
I think probably cyclosporine is a good option because there is immunosuppressive specific of LGL clone and medulla marrow hypoplasia. But usually it's difficult because patients have been previously exposed to cyclosporine or tacrolimus and so on. So I think the efficacy of cyclosporine in such circumstances is a little bit disappointing. And probably once possibility to treat this patient with ruxolitinib for a specific cytopenia occurring after stem cell transplantation. But I think just a few cases, so it's difficult to say if there is the best option or not, but maybe it's worth trying this drug in this context.
And if I can ask one more question, Dr. Amit.
Go ahead, please.
So you mentioned a lot about dysregulated apoptosis, especially towards the end of the spectrum of the LGLs. And there is data for hypomethylating agents with TET2 and other methylation-related genes coming into the picture. So similar to the success of azacitidine and venetoclax in AML, you see any role of venetoclax coming in this LGL along with hypomethylating agents for dysregulated apoptosis?
I am very, very cautious because I won't say that I have good experience of hypomethylations. So we have treated a bunch of patients, I think less than 10 patients. So it's very difficult to say that's a good option or not. I just mentioned these patients with extraordinary response to 5-ASA, but it's just one case. So, I think we have to wait the ongoing trial with oral 5-ASA to see if there is definitive response. But my feeling is that probably we have to probably adapt our strategy according to the different molecular features and to know what is the best option. And also in the context of TET2 mutation, we have definitely to eliminate underlying myelodysplasia because there is a link between LGL expansion of myelodysplasia. So in case of TET2, just maybe it's not so obvious to say that it is a definitive LGL leukemia, or maybe it's just NK or T LGL clone in the context of myelodysplasia. But regarding I think probably it's a good option, but I can't say more because we have so few patients which have been treated so far. So it's difficult to answer.
Do you see any role of venetoclax or BCL2 inhibitors in the subset because it will inhibit the apoptosis or promote the apoptosis? Sorry.
I think probably there is a rationale to use venetoclax BCL2 inhibitor, but I have not so far the experience.
Thank you.
Thank you, Dr. Somu. Sir, from the same note, the case what you showed was TET3 mutation positive, and your patient worked with 5-ASA because the patient was TET3 mutation positive because TET3 causes hypomethylation, which you showed. So should we first see the patient, whether the patient has TET3 mutation positive and then offer them 5-ASA? Otherwise, it's not going to work.
I think we it's I to say it's scientific consideration. I think it's very difficult to draw any definitive conclusion. I think probably there is a rationale to use 5-ASA in the context of phosphorylation of STAT3 and activation of hypermethylation. But yes, interesting, but it's exactly what I answered to your colleague. We have we have no follow-up. We have so few patients treated that definitely I think the ongoing trial will be very interesting to know, but it's oral 5-ASA. It's not exactly the same thing, but yes.
Thank you, sir. Dr. Shilpa Gupta.
Good afternoon. Good talk, sir. Thank you so much. My questions would be, I have a patient basically, LGL, and has a borderline high creatinine. How do you handle these drugs, all the three nephrotoxic drugs in this context, endoxan, cyclosporin, and methotrexate in a CKD patient with LGL?
Excuse me, I can't hear you very well. Could you just repeat the question because I can't hear?
1 minute, I'll try again. Can you hear me now better, sir?
Yes, we can hear you. Please go ahead.
Yeah, so a CKD along with the LGL, what would be your drug of choice and how would you monitor these patients? Because all the three drugs which are available and the armamentarium right now are nephrotoxic. So maybe a patient who's on dialysis, not on dialysis, what would be your drug dosage and how would you monitor?
So, sir, the question is, patient of LGL leukemia having chronic kidney disease, what would be the best line of agent in from all these three drugs in armamentarium, whether you go for methotrexate or cyclosporin or cyclophosphamide? And if so, what would be the dose whether the patient is on dialysis, and what would be the dose whether the patient is not on dialysis in a case of chronic kidney disease?
Okay. Personally, I've no experience of patient with dialysis and LGL leukemia. I say that in the context of renal insufficiency, but no patient with dialysis, I think it's very difficult to use a cyclosporin. And probably in the context of dialysis, it's also difficult because you have to monitor the dosage of cyclosporin in blood, and you don't know exactly what is the efficacious dose as regarding the renal insufficiency. So in dialysis, I would recommend metho or cytoxan, probably at low dose. Probably cyclophosphamide 50 milligrams per day, that's enough. And metho 7.5 milligram per meter square is not a very high dose. You can maybe use 10 or 15 milligrams in outside the renal insufficiency. So probably for this kind of patient, metho or cytoxan at low dose could be a good option.
Okay. Thank you, sir. One more question. How do we assess the response? Is it only a clinical response being transfusion independent? Or when the patient is on methotrexate, as you showed, the data is more than 60% relapse rate after stopping methotrexate. So how long do we continue methotrexate?
Yeah, that's a good option and we good question, and we are working on the first the LGL response criteria. So usually we recommend to assess the response between M4 and M6 because we can observe some late response. So between M4 and M6, and usually we pursue the treatment until M12. And I understand that for when you use methotrexate, like in rheumatoid arthritis, you can pursue the drugs, but it's always difficult to know how long. So maybe you have to monitor the persistence of LGL clone, and we have very interesting data comparing the MRD status regarding the different drugs that we have used in first line. So usually, yes, you can treat patients with methotrexate for longer times than 1 year. And cyclosporine, also you can also, but I mentioned that with cyclosporine, you just correct the cytopenia. And as soon as you stop the drug, usually the patient relapse. And the relapse rate is also very high after stopping methotrexate. The only point is that we can observe after cytoxan very long-lasting response and also molecular response, but it's not the case for methotrexate and cyclosporine.
Thank you so much, sir. Thank you.
Thank you, Dr. Shilpa. So there are some few questions from the audience. Dr. Kunal Chatani wants to know that is it mandatory to do T cell receptor rearrangement studies in all the patients of TLGL?
No, I don't think. I think for the vast majority of patients, if you have a specific phenotype and TCR clonal assessments, that's enough. You know, a patient having neutropenia, maybe splenomegaly, and LGL count expansion with monoclonal feature on TCR gamma rearrangement, I think that's enough. You know, I think it's probably for the borderline cases. We do it routinely in our lab, but we centralize all the cases in France, so we have the specific phenotypic patterns and also the molecular study with a dedicated specific NGL panel. But I think in routine, probably phenotypic and immunophenotype and TCR clonal assessment is okay. For NK subtypes, is more subtle because yes, in sometimes clinical context, NK phenotypes that's enough, but in sometimes you have to definitely add with the notably with the KIR expression also the molecular status to assess the difference between reactive and NK LGL leukemia.
Thank you, sir. Another question from Dr. Kunal Chatani. What is the dose of cyclosporin recommended in TLGL leukemia?
Yeah, it's 1.5 milligram per kg twice a day.
Twice a day. So that will become 3 milligram per kg per day.
3 milligram per day, and at
Individual
least 4 months exactly. Yeah, and to monitor the be aware, be careful of the kidney function and hypertension and so on, like everyone.
Thank you, sir. Another question from Dr. Prem. Is there any autoimmune disorder association or which leads to later development of LGL leukemia?
Yes, as I mentioned, there is a bunch of autoimmune disease. So first is rheumatoid arthritis, Sjogren disease, and thyroiditis, so thyroid disorder, autoimmune thyroid disorder, and also autoimmune cytopenia. And we have published a bunch of patients with vasculitis, cryoglobulinemia, and yes, that's the main disease that we can observe in LGL leukemia.
Thank you, sir. Another question from Dr. Rani, that whether if all the patients of LGL leukemia, they do come to you with an advanced stage or a terminal stage?
What do you mean?
At presentation, are all the patients of LGL leukemia coming to you at presentation really advanced to start with?
You mean
are they really aggressive?
No. I think usually I mentioned on the first one of the first slides that usually at diagnosis only 50 to 60 or 60% need treatment at the time of diagnosis, and about 20% of patients won't need treatment for a long time. So it's about what we see. What is interesting, is that as soon as you have to treat the patient, probably the patients are more aggressive, I would say, And it's probably the reason for why we observe in our program 70% of STAT3 mutations incidence, which is quite higher what it was previously published, because it was published on a whole series of LGL leukemia, whatever they are treated or not treated. But in our protocol, the starting point was patients need therapy. So probably they are quite in a more advanced stage of the disease, and it's probably the reason for what the STAT3 mutations, which is probably a later step of ontogenesis of LGL leukemia occurs.
Thank you, sir. I've finished all the questions from the audience. Any discussion want to ask any other question? Well, so I think, sir, there are no more raising signs and no more questions from the audience. So thank you so much for that fantastic and lovely talk. That was quite good learning for all of us for this rare disorder. And
Okay.
you put it out so very well in your presentation. And what a wonderful discussion we had, sir. Thank you so much for being with us today.
It was my pleasure.
And now I request Mr. Sumit Kumar Madan to go for final vote of thanks.
Thank you, Dr. Lamy, for sparing your valuable time. It was a lucid presentation which provided a holistic view of managing LGL leukemia and which was followed by a very, very engrossing discussion. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank our chief guest for the day, Dr. Gaurav Dikshit, all the discussants and participants who have joined us for this webinar. Special thanks to Dr. Amit Khurana for navigating this entire webinar in a highly proficient manner. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. So thank you so much, everybody. Have a wonderful Sunday.
Thank you. Thank you.
Okay. Thank you.